So thank you very much indeed, Tyra. That was really superb and just a tremendous overview of the epidemiology in Denmark, as well as the particular challenges for opening up the schools. And I think many public health colleagues will be very envious of some of the capacity that you have, both for testing, but also for pulling your data together. Now, one of our queries related to comparing surveillance in Denmark and Ireland. So perhaps I might just break that down a little bit, if that's okay. You mentioned that you do 30,000 tests per day and have been doing that for a long time. So I'm wondering if the trends in the positivity rate give you advance warning of when the number of cases are on the up, and particularly in terms of, say, hospitalizations, or indeed advance notice of when the general practitioners are likely to have increased workloads.
Yes, so we follow, well, it has mainly been the recent week that we've had this very high number of tests of 30,000 a day, but it has been on that level, it's been increasing continuously the last weeks. But we follow the percentage of positive samples very closely, and we also really tend to see an increase in the percentage of positive samples before we see an increase in cases. We can also see, because now when we have this very extensive testing, that it's very sensitive to detect changes, because actually in this period, in the last search we saw in cases, we haven't seen an increase in hospitalizations at all. And I think that there may be several reasons for that. One is that actually the elderly people, they seem to really isolate themselves. So we have seen a change in the age distribution. So it's mainly younger people who gets infected now. And then also, of course, we will, with this test capacity, we will detect more cases than we did previously when the capacity was not so high. And so I think, and then also I think we've been very good at keeping protecting the vulnerable groups, in particularly at nursing homes. So we haven't had very few cases at nursing homes for the last months, after we started to do this very intensive testing every time we see one case in a nursing home. So I think so now we can really, and it seems we had this increase in a few geographical regions in the last weeks, primarily in the Somali society, and we have then done a lot to stop these transmission chains, and now we see a decrease again. So we are able to use this testing to follow very closely the transmission in the society at an early stage, I think.
Thank you. Another question that's come in is, can you estimate the population that's actually covered by the testing? Presumably there's some repeat testing. Is there any geographic focus to it, or is it a mixture of some who are maybe in geographic areas that are at risk, or is there a system for it?
I can send you a link to our surveillance website after the presentation, but we do look into test incidents by municipality and display these figures on maps, and also in smaller geographical areas. And there are some differences in the testing activity in different areas, probably also depending on how close the distance to the testing facility. But what we can see now is that in the beginning, we mainly saw cases in the municipality region, but now we can see that the number of municipalities that have cases has really increased a lot the last period. So it seems as if they test quite a lot also locally, and the virus is there all over Denmark. So we have the potential for these outbreaks everywhere in Denmark now. It's not like in the beginning where it was kind of, we just saw cases in the municipality and then no reports of cases in other areas.
Thank you. That actually is quite similar to the situation here, where the Dublin area, the metropolitan area, was particularly affected at the beginning, but now there are cases far more widely across the country. The other reason that epidemiologists and public health doctors would be very envious of you is your capacity for record linkage. And that's partly because of your unique identifier, but it's also because it's both legislatively and culturally acceptable. I don't think it would be in this country. And I'm curious, every time this sort of issue comes up in this country, people say, oh, GDPR, we couldn't do that. So why is it that Denmark, that's also within the EU, doesn't have the same data protection barriers that we have?
Well, I think we are continuously being challenged also with the GDPR in Denmark, but I think we have a political support because, and particularly now, we have gotten access to more registers that we have had access to before during the COVID-19 epidemic. For instance, these access to the register of occupations. Normally, we don't have access to that, but that has been implemented during the epidemic because there was so much focus on whether there were some occupational groups that were harder hit than others. So I think we have really used this pandemic as a momentum to get access to more data than we had access to previously, and there's also been a support to that. But I think all the time the legislation is a little behind the development of what we can do. So we are also now changing the legislation continuously so it can support the things that we actually want to do and the things we do. And I think maybe sometimes we do something in the because we think that it's relevant from a public health perspective, although the legislation is not quite in place to really support it, but then the legislation follows after.
So does that mean that the legislation is there specifically just for public health?
Yes, I think we have our own epidemic act that is being revised now, and where we are trying to get this kind of put into the legislation, that when we make surveillance of when we have surveillance in place for infectious diseases, they're not only based on reports from doctors, but also based on information that we can capture from registers.
Thank you. I have just two other questions that have come in on the box that are particularly related to public health, and perhaps a third one, and then I'll hand you over to Ellen Crushell on the more paediatric focused ones, and parents and teachers and so on, if that's okay. One question is about, have you done a seroprevalence study? But my read of it would be that in many ways your current, well, I suppose the seroprevalence would pick up the asymptomatic cases. So have you thought of doing that?
Yes, we have done already one seroprevalence study where we tried to do invite a representative sample for testing. Unfortunately, we had a very low. No, that was just for a virus test. We are doing the first real representative serological study now, where we are inviting, I think it's 15,000 inhabitants from all over the country, and also comprising children, I think down to 12 years of age, for both PCR testing, but also for serology testing. And then we hope we will have a high participation rate. But so we don't have any results from that now, but it's just we've sent out the invitations, I think, last week.
Thank you. The results will be interesting because of the huge amount of testing that you've already done, and the PCR testing. Another question related to the health economics of such a vast system of testing and how you justify that. And the questioner is asking, could the money be spent better somewhere else? I'm sure you can justify that.
Yeah, I think we need to do some kind of evaluation at some point, whether it could be spent better. I think right now, I mean, we see so few hospital admittances and deaths, so that could definitely be argued, and I think we need to do an evaluation afterwards.
That's very helpful. And coming back to children in schools now, the management of outbreaks in schools, have there been, I suppose, first of all, there have been cases in schools arising while children are actually in school, and then have there been any outbreaks within any of your childcare or school facilities?
I think that's one limitation with our surveillance system, is that we cannot yet, outbreaks are not reportable to us, and right now we cannot link with registers children to school classes or schools, but we're working on that, and that will be put in place. So we don't have the overview of outbreak, but what we hear from the Danish Patient Safety Authority that do all the contact tracing is that they see these sporadic cases with one case in a school where they do just contact tracing around that case, and then it's rather few outbreaks with more than 2 or more cases that have been seen in schools. It's not so common.
Thank you. And that's probably a good point at which to pass over to my colleague, Dr. Ellen Crushell, who's the Dean of the Faculty of Paediatrics. But thank you so much for such interesting information.
Thank you very much, Tyra. That was a wonderful presentation. So we're getting ready to open our schools. Some have opened yesterday and the rest will open in the next few days. A couple of questions have come in about mask wearing. So we're recommending that secondary schools, so from 13 on, will wear masks, but there's no recommendation for primary school. The recommendation is that there's no need. What are you recommending at school and in the public in terms of mask wearing?
We have only one recommendation, and it started last weekend, and it's mandatory to wear masks in public transport and nowhere else. Okay. So not in schools and not in other public spaces yet. So only mandatory in public transport, and that was just implemented 1 week ago.
And so for the teachers, are they just encouraged to maintain a physical distance from the children, or what happens in the classroom?
Yeah, they're just recommended to maintain physical distance and of course increase focus on hand hygiene.
Okay. We have a lot of anxiety at the moment about teachers who may have underlying conditions. We hear that teachers who are pregnant are whether they might be at high risk, do they get or if they are otherwise medically vulnerable. How are you addressing that problem there?
I think it's the same as as outside work, that they have to be extra careful with the physical distance and hand washing. So I don't think there's any recommendation that they should have other tasks or anything within the school, that they can continue to teach children as they have always done. But of course, there has also been a concern from these from the teachers, but I think it's been quite reassuring then to show these data we have on testing and how many test positive among people working in the educational sector, where we can't see that they seem to be especially at risk.
Yeah, and at which point of the epi curve were the teachers tested at?
I think I mean they are just there are no special recommendation for them to be tested, so they are just a part of the normal offer to all people who can get a test when they want. So it's just observational data that we have collected here on those who have been tested for any reason. So we haven't done any systematic testing of school teachers or anything.
Okay. The other thing that will be of interest is a child who has a runny nose. The suggestion here is that if it's a runny nose and otherwise nothing else, the child can go to school. But say, I think from what you say there, that child would have to stay home, or?
No, I think in the recommendations for the GPs who kind of have to decide whether a child should be tested or not, if you contact the doctor, according to the case definition, it's stated that a runny nose, only a runny nose, is not a kind of specific symptom for COVID-19. But I think what we see in school is that often the children are sent home with very, very few symptoms. And I think they sometimes also sent home even with a runny nose. And of course, that's a challenge. And that's also, I said, I had a child I tested yesterday. I'm sure he hasn't got COVID-19, but I'm concerned that he will never be allowed to school unless I have this negative test, although he had very few symptoms.
And leading on from that, so say your child can't go back to work or can't go back to school, and you can't work for a period of time. Is there a formal arrangement there about, supporting parents who may have to take time off work because their child is sick?
Yeah, in Denmark we have, the child's first and second day sick leave. So you are allowed to stay home and get a salary for 2 days with your child. But in this situation, you can also sometimes you can risk that a child is a close contact to a confirmed case. So your child has to stay home in quarantine, and you have to look after the child. I don't know. I think it's different from different workplaces. But for instance, at my institute, then you are sent home, so you will still get a salary, and then you can try to work if you can. But if you cannot. If you work in the laboratory, you cannot work from home in that day, and then you will still get a salary because you have been sent home because you have to look after your child who is in quarantine until the child has a negative test.
Okay. And on to the medically vulnerable children. Are there many of them being left at home and homeschooled at the moment? Is there a significant proportion of kids?
Yeah, I don't think so. I haven't really heard of that they are staying home. No, I think they go to school.
Okay. That's the recommendation here also, yeah.
That they stay at home?
No.
They go to school. Yeah.
You seem to have a lot of public buy-in and kind of, from what we can see, and I just wonder how you manage that. There's high levels of anxiety here over the last few weeks about the schools opening. Mm-hmm. How did you manage that, and did you consult parents and teachers about the school, about the reopening of schools and procedures that were going to be put in place?
I think there was a lot of concern just when we opened for kindergartens and the lowest class, and they said, well, you're experimenting with the children, but I mean, the only thing we could do was to say, well, there's not so much evidence to support the role that children plays an important role in transmission. And then I think there was a lot of criticism to begin with, but I mean, for our luck, we saw this continuous decrease. So of course that was kind of reassuring that it's not such a big concern to send children to school. So I think that has made it easier for the second round, where we started to open the schools for the older children.
Yeah, and I heard that you used public parks as well for outdoor school.
I think I didn't mention that. I think the schools are recommended to do more outdoor schooling, and I can see that in my children's own school, that they're doing a lot of excursions to different places and also try to stay out much more than they did before.
Okay, very good.
But of course that will be more difficult when it gets colder.
There's also a bit of anxiety about not necessarily the child, but a child of a very immunosuppressed parent, whether that child should go to school.
Mm.
Yeah, I mean,
and I think there's been the same concern in Denmark, but I think we still recommend that they should go to school.
Yeah, well, I think it's beneficial.
Yeah.
Okay. Great. One other question on contact. If a child is close contact from a school contact and needs to self-isolate, do the parents also need to self-isolate?
No, they don't need to self-isolate. So the child has to stay home until day 4 after exposure, where we recommend the child to be tested. So all close contacts are tested at day 4 and day 6. And if they test negative at day 4, then they can go to school again. But they should still have a test on day 6. So that's also what the test capacity is used for, is to test close contacts so that you can shorten the quarantine period.
Okay.
And kind of release people who test negative on day 4 after exposure.
Okay. Great. And if you have a positive child, a child who tests positive, is the parent subject then to the child's 14 days plus another 14 days?
Yes, then the parent looks after the child, can cohort isolate with the child, and then the parent has to stay home for further 4 days after the child gets well, and then get tested, and if they're negative, then they can be released.
So that would be the 14 days plus 4.
Yes, exactly, yeah.
That's interesting.
No, because we say that if the child is the child can be released 2 days after they are without symptoms. So actually, the parent can be released 4 days after, 6 days after the child's symptoms has stopped.
Okay, so that's quite different to ours. If we have a child who's positive today, they need to stay out for 14 days. I think, is that correct?
Yeah, but that's not in Denmark. We say they can stay home until until symptoms stop, and then a further 2 days.
Okay, very good. Wow. And one question on the class sizes. Here, typically our classes are about 30 pupils. Is that the same in Denmark, or are they smaller?
No, I think it's about the same, or maybe 28, I think is the highest limit, 28 pupils in a class.
Okay.
Yeah, and I think that has also been a challenge with the spacing in schools, because also some schools have that do not have space for a whole class to kind of to allow for physical distance of 1 meter between each pupil. And I know that some schools, they can get a special kind of permission not to let the pupils be closer together in the classes if they cannot meet these requirements.
Okay. Thank you very much. I'll hand you over to Mary. Thank you.
Thank you very much, Tyra. That was a fantastic presentation. The data you have and your analysis of it was brilliant. And I think that's the type of data that we can show to teachers, healthcare workers here. And it's something we aspire to doing here also. I suppose I really would like to thank you for accepting my invitation, and I'll thank Tia separately. I think our ability to share our experiences across Europe while we live differently. We are part of the EU, and learning what people do well, and in some places what they don't do well, has helped us and continues to help how we do things. I think the cost effectiveness of testing will be shown to be absolutely cost effective in allowing us to open up society and our economy and getting kids and young people back to school and work and sport and so on. So look, on behalf of I'd say the people of Ireland, because we have all wanted our children to go back to school, on behalf of the Royal College of Physicians, and you have Ellen and Emer here representing Paediatrics and Public Health. Just a thousand thanks for sharing your experience, your data. We hope to reciprocate when we're all, I suppose, with a bit more knowledge and a bit more experience to share with our colleagues. I just want to thank Rebecca McEntee, who helped connect us all in together. We wish the people of Denmark continued success. We will track your continued success closely, and we'll share this information with our wider doctor audience and with our policymakers. So again, thank you for taking the time to help us in our journey to living with the virus.
Yeah. Thank you so much, and I was very happy to be invited for this, and good luck with the school openings.
Okay, thank you again, and thanks to everyone who's joined us. Bye-bye.
Bye.
Thank you very much. Bye.